Greg Wilburn. I'm the respiratory therapist for Specialized Medical Services. And we are going to talk today about oxygen therapy, just general oxygen modalities, what to put a patient on, and then any other questions you guys might have, anything that you've run across that you want to ask questions about. So we're just going to read through this. There's 6 questions at the end. Don't be nervous. We'll answer the questions together at the end. There's probably going to be some things on this that are going to be, I'm going to be in conflict with. I have not read, this is SMS's protocol. So as I read through it and I tell you what's the real world versus what they're telling you, we'll kind of go back and forth on that because you've seen the real world, okay? So first things, the purpose for the oxygen is, obviously oxygen is a basic human need. The air that we breathe is 21%. Quick little thing, for every liter of oxygen you add to a patient, generally speaking by nasal cannula, you can add 3%. So if we put a person on oxygen at 1 liter, they are now getting the equivalent of about 24% oxygen, okay? So you may have seen orders come from the hospital, patient on 28%, okay? That equivalates to about 2 liters of oxygen. It's not necessarily a hard 3%, but if you use that, it'll get you pretty close to where you need to get. So if you ever get an order that says 28% via nasal cannula, you can just divide that out by 3, all right? And you'll get to your what liter flow you need to have for that patient. So let's see. Okay, indications for oxygen use: obstructive pulmonary disease, restrictive pulmonary disease, hypoxemia, cardiac arrhythmias, shortness of breath. So obstructive would be COPD, like our 3rd shift girl there is experiencing at home right now with her father. And you see probably 75% of your patients in here that are on oxygen are probably due to that. And or hypoxemia, which is just you do a pulse ox on your patient. They are not, their oxygen saturations are low, so you put them on oxygen. And that could be for many different reasons. So oxygen's a drug which must be ordered by a physician. That's the first thing. Oxygen is an odorless and tasteless gas. It's non-flammable, which that's important to understand. It does support combustion. So I could stand here with a cigarette and hold the cigarette to this flow source. The cigarette would turn to flame, but the oxygen will not explode. That's a misconception that most people have. And we allow that to happen for the simple reason it protects people, okay? And that's what, if everyone thinks, oh, it's going to blow up, well, at least we know that you're going to think that, be careful around it, right? But you cannot explode this, okay? It won't explode like a bomb because of a source of fire, all right? But it does act as a combustible. That cigarette that I was telling you about would just, in seconds, go down to the butt in no time, okay? And it would actually, the paper would start to burn, and the tobacco. So that's what oxygen can do. It is dangerous. You may have read, seen, heard on the news, a patient at home smoking. The reason that there was a problem is the plastic that the patient probably had on while they were smoking at home caught on fire, and it burned the patient. I've seen people's faces burn, taken to the hospital. You've seen this? So that's what happens. It's not the oxygen, it's what the combustible that we're talking about, whether it's plastic, wood, whatever. Bedding materials, patient clothing, those things. Okay. Types of oxygen. You guys do not have this, but we can talk about it. one liquid oxygen, which is oxygen that has been, what is the term they use? I can't think of it. It'll come to me in a little bit, but anyways, this is compressed gas, and this is a concentrator. These are the two sources that you guys use here. Liquid oxygen is actually a liquid that you may have seen in home use. It comes in like a big beer barrel. And the reason they do that is we can put about 10 gallons of that in one of those, and it expands 650 some times. So you're getting a large amount of oxygen as opposed to this. It will last the patient 10 days on continuous use. As it heats and turns back to a gas. It's not in the liquid form, but we draw it up out of the base of the unit, run it around some warmers in the unit, and it turns back to a gas, and you end up having like a gaseous product, okay? But the reason we do that is for storage. We can talk about it real quick. It's stored at 297 degrees. That's the danger with the liquid oxygen, is when you fill them, you can be burned with the frozen liquid oxygen. They should be kept upright at all times. The portable tanks that they provide they weigh about 6-7 pounds. They do not have wheels. You carry them on. It's for a more mobile patient. They're kind of going away from that now, as most companies are seeing that as, with all the difficulty of the patients and the aides who fill the liquids being burned by it, by the fill, and the danger factor. They've moved away from that and pretty much going to mostly all cylinders, at least in my area in Ohio. I know some still do use it. So the compressed gas is what you guys use here. This is an E cylinder. I saw in your O2 closets you do have some cylinders about half this size. Those are D cylinders. There are different size cylinders for compressed gas, but your basic tank that you need to worry about is an E cylinder. Are the tanks up in the storage unit that are not self-contained, are they like hospice? Does hospice provide tanks here? Or those tanks are your guys too, do you know?
They usually provide their own tanks. They usually provide their own concentrators.
Well, the hospice, no, I'm talking about the tanks.
The tanks?
I noticed you had these that were delivered from us, and then you had just regular cylinders that you have to put a regulator on.
Mm-hmm. That I'm not sure.
Okay. Has everybody changed a regulator here? No?
Not for a long time.
Okay. Because you have these, how long have you guys had these, do you know? Over a year or so?
Yeah.
Yeah. If you want, I mean, we can go over the changing the regulators, but if you're not using that and this is what you have, we don't really have to press on with that. So, one thing to remember, what I'm doing here is not safe. Cylinders should not be on top of tables. They should be in a container, a cart, or in a rack, okay? They can never not be in a rack, container, or cart, okay? So if you're changing it, put it in the rack, put it in the cart, and that's where it should be. The only reason I have it up here is so that you guys can see. All right? All right, secure tanks in a cart, chained to the wall, or a cylinder rack. Concentrator. It plugs into the wall. This really, what this does is it doesn't concentrate oxygen as much as it eliminates nitrogen. The room that we're in is about 78% nitrogen. This machine takes the nitrogen out of the air and puts the oxygen in a little canister, and then the patient breathes out of that canister in here. So it's a nitrogen eliminator, but it's called a concentrator. Let's see. It's the most common, these days it's the most common, oxygen. Concentrators and their filters should be maintained for optimal function. This actual machine does not have a filter that you guys can claim, okay? Yeah, there is one in here. That needs change yearly. And then somebody from my company will come by and do that. But you guys don't need to change a cabinet filter, what we call a cabinet filter, anymore with these newer concentrators. You may have some older ones that you do have filters on. I'm not familiar with your building enough to know if all you have are the Everflow blue ones, or if you have some old ones with filters on the side. Those need to be cleaned. We'll talk about that in a little bit. One of the big things that keeps the concentrators, well, it makes them overheat, is curtains in rooms. By putting the curtain up against a concentrator, it blocks the intake of the air that it needs. With these, it's not so bad. Some of the older models, it became a real problem. These seem to function okay, but just keep in mind, keep the curtains away from the intake on the concentrator. So you need three things for your oxygen. You need physician's order, a no smoking sign on the door of the patient's room, and obviously your equipment that you'll need. And let's see. We'll get into storage areas, that's further. Avoid open flames, we already talked about. I was telling you about it won't explode, but open flames are an issue to the patient. We don't like to use anything electrical with a patient on oxygen, like haircut, stuff you can give someone a haircut with, something that would possibly cause a spark. Anything like that, just be vigilant about that. So, you're given oxygen, you want to verify the order. Use standard precautions as necessary. Gather your equipment, which would be a concentrator and or compressed gas cylinder. Your mode to deliver the oxygen, whether that's a nasal cannula or the mask, which we will talk about here in a little bit. You will explain the procedure to your patient. Humidity, that's a good question. You don't need to use a humidifier on 3 liters or less. Okay? So once you start getting into 4 or 5 liters, you may want to put a humidifier on the machine. Okay, so apply the device to the patient with liter flow, place your oxygen signs, document in the patient file or in the chart. Nasal cannula. So a nasal cannula should be used with this machine here from 1 to 5 liters, okay? You can use an oxygen concentrator. Actually, it says here 1 to 6, and that's fine. Which is about 45% oxygen if you get into that fractionally inspired O2 is what FiO2 stands for. So the amount of oxygen is not exact. It can be somebody on 2 liters can be getting 100% oxygen, especially a little old lady, 90 pounds, tidal volume not very large, versus somebody on 5 liters doesn't mean that they're getting more oxygen necessarily. It just depends on the tidal volume. So remember that. Right, so your tubing should be changed out weekly, dated, I might add. Do you guys, nursing, who's nursing here? You guys date and change these out weekly?
Yes.
All right. And there should be some sort of respiratory bag on the piece of equipment to put the cannula, mask, whatever it is, when the patient's not using it. Keep it clean. So getting back to those percentages I was telling you about, room air is 21%. You can see all the way up to 6 liters is approximately 44%, it says. So, now there are high flow nasal cannulas, and all they are is a bigger diameter so that you can pull in the oxygen without it causing a what we call the machine to have back pressure. And you guys have probably seen this. If it was plugged in, I could show you. Where you have something, you've got your leader set to 3, 4, 5, whatever it is, and there's an obstruction, the ball will drop. That's called back pressure into the unit, and the patient's not getting the amount of oxygen that they need to get. So a high flow nasal cannula takes care of that part of it. And there's also a high flow humidifier. So if you ever get a patient that is on 6 liters and above nasal cannula, have central supply, get a hold of SMS, we will send you the high flow cannula and humidifier. It's not something that most people keep around. So we talked about changing it out weekly and as needed. An oxidizer nasal cannula. I don't know if you may have seen these. It's they can have a pendant, or they can be real thick like a mustache. And what they do is they act as a reservoir to conserve oxygen. So when the patient takes a breath, they're getting all the oxygen in the pendant or all the oxygen in what they call the mustache, and it saves on you putting somebody on higher flows of oxygen. It takes high flows of oxygen, but it can it will reduce the amount of oxygen you need. Let's see what it says here. It makes the oxygen available at the beginning of the next inhalation. This will use 1/2 to 1/4 the flow rate required by a regular nasal cannula. So that, again, that would be a doctor's order for this. It's a special piece of equipment. Usually they give them to patients that are on 6 liters and above nasal cannula, so that we can use about 3 to 4 liters on the patient and still deliver high flows of oxygen to the patient. Yeah, and normally, if you look there on E, it says change out every 3 weeks. We usually say once a month for that optimizer. Again, place in a bag when you're not using it. Simple mask we have here. Simple mask is never use this piece of equipment unless 6 liters or above, okay? I know it says 5 to 8 on this piece of paper, but that's what I was telling you before. I will tell you 6 liters. We want 6 liters to be able to blow out the exhaled CO2 that the patient's expelling. And lower amounts of oxygen do not do that. Therefore, the patient will rebreathe their own CO2, and you'll get false readings on your when you're trying to do a saturation on your patient. Again, the amounts are not exact, but roughly 50% on this piece of equipment. is what you're gonna be able to provide to your patient. They do not recommend using a concentrator with this. You don't need a humidifier. Venturi mask. Have you guys had Venturi mask here? Where you have like little jets, or it's a specific FiO2 ordered by the physician, where it's a dial type, where you may have dialed at 24, 28, 35. We use that with our COPD patients so we can guarantee that they're not going to get, you know how we've been talking about, it's generally speaking, they're going to get 2 to 5. Well, with the Venturi mask, we guarantee the patient. If we put him on 28%, that's all that's coming out of that mask, okay? It is a mask like this one, but it has a little jet that we can control the amount of air we're mixing with the mask. That's a Venturi mask. And you may get an order for one of those from time to time. Again, it's not compatible with a concentrator. You would probably, to start, you'd be on cylinders, and I would have to bring you in a high flow concentrator to use with that. Do you have any high flow concentrators here? 10 liters, 8 liters? Do you?
There's at least one out there.
Okay. All right. Then you could use that with the Venturi and with the other mask. All right. Partial rebreather and non-rebreather, okay, which are, anymore, one and the same. A partial rebreather is just like a non-rebreather, except for this mask, as you can see, has these little tabs on it. We put a one-way valve on here. That way when the patient takes a breath, it closes, and the patient can't get any air from the outside. With this mask on, which is called a simple mask, the patient can draw air in through these air holes, even though there's air coming in through the mask. That's why it dilutes the oxygen. With a non-rebreather or partial non-rebreather, we put these little plastic tabs on here, and that blocks those ports. They can exhale out against it, but when they go to inhale, it blocks the ports, and then all they're getting is oxygen. Therefore, a partial non-rebreather has one on one side. A complete non-rebreather has both of these are blocked. Okay? So now you're talking about this is up to 50%, the partial is up to 80%, and a full non-rebreather is, we are trying to guarantee up to 100% oxygen. All right. So, quick about the non-rebreathers, both of them. You want to, they both have the other thing they have is a little reservoir bag on the bottom. You may have seen that. You want to fill with your tank. You turn your tank on, occlude the end, and the bag will fill. You then place that on your patient. If the bag collapses, you need to add more oxygen. That's important about non-rebreathers, either one of those, okay? If the bag collapses, that means the patient's taking all of that oxygen in. You need to add more. We do not want that bag to deflate. Okay, so if you've got them on 8, the bag collapses, go ahead and turn it up to the max, okay? Because you've got the squat on the way, okay? I always say start at the, and you can always work your way down. All right. So clinical considerations, let's talk about these CO2 retainers. Some patients are sensitive to O2 and have potential to stop breathing if the oxygen becomes elevated. What it does, it knocks out in the brain. It tells the brain, hey, we don't need to breathe, we have plenty of oxygen. And so the patient obviously would become in danger there. They should be maintained on their saturations near 90%. And generally speaking, we always correct to 90. We're not trying to get to 95, 98. We always correct to 90. And we're happy there. And then we try to let other things work their way to get the patient back to normal, okay? As patients reach the age of 80, they may be able to maintain their saturations less than 92%. The body is amazing. COPD patients who don't realize they have COPD may enter the hospital for the first time for some other reason. That's usually when they find out they have COPD or some other, and their saturations, they may be running at 86, but they didn't know it. 85, 84, because the body compensates. So, age is definitely a factor. Patients with anemia, they may have high O2 saturation, but remain hypoxic due to their low hemoglobin. All right, the Venturi mask. Oh, there's a good picture of it. It's the dial that I was telling you about. You just simply dial the flow that the doctor has ordered, okay? And turn it, that dial corresponds with a setting on the mask. It'll tell you 6 liters for 28% or 3 liters for 28, whatever it is, whatever brand it is. And you just simply set the concentrator or the cylinder to that amount and set the dial. And your Venturi mask will take care of the rest of it. We talked about the partial non-rebreathers. And I would tell you that both non-rebreathers are anywhere from 6 to 15 liters, generally speaking. Okay, again, the bag is the determining factor. Okay? I know it says here that with the non-rebreather use 10 to 15, but those are just general guidelines, okay? So, last page, take our test. Oxygen is a drug. True. B, is it flammable? No. C, 31% room air? No, it's 21% room air. So D, odorless? True. So E is the answer. A and D are the correct answer. What are the 3 types of oxygen? Anybody know the 3 that we talked about?
Liquid,
Liquid,
compressed gas,
compressed,
concentrated.
that's it. You should clean your concentrator filters.
Yearly.
All right, now, I did say that. But what they're talking about here, I think, is the cabinet filter, which I told you you don't have, right? This one, you're right, is yearly, so that's kind of a trick question. But weekly for your cabinet filters. If you guys have those concentrators, and if you've seen them with the black filters on the sides, right? Those need to be cleaned weekly, and I think that's what this test is actually talking about. It's okay to use a standard nasal cannula at 8 liters a minute. True or false? That's right. A simple mask should be used with a concentrator at never. In an emergency, you should use a nasal cannula at 6 liters with humidity, a non-rebreather with a concentrator at 10, oxidizer nasal cannula at 5, a non-rebreather mask with bag inflated using a green cylinder or liquid O2 tank.
D.
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 Now, again, I told you that I'm going to have problems with some of the stuff on here. In the emergency part of what we're talking about, grab this. This, or even the 10-liter concentrator, can't help you because we can't go above it. This can, okay? It'll go to 15 liters. In an emergency, grab this and your non-rebreather mask, okay? And then, if we get our patient where they're stable, but the doc says, I want them on the non-rebreather, then you can put them on the 10-liter if you've done everything that I've said. where you put them on the 10 liters and the mask is staying inflated, then go ahead and use the concentrator. So it's kind of iffy, but look, for this test, the answer is D, okay? And if you guys will put your name and date those, that way you can give them to Amy and she'll know who was here, I guess. But I don't need them back. And that's all I have. Do you guys have any questions?
Nope.
Thanks for coming. Does anyone need more pens or? Still got some?